my name is Marc Succi. I'm a radiologist at Mass General. I'm one of the strategic leaders at Mass General Brigham Innovation, and in a past life, an inventor and entrepreneur myself. And I'm joined by...
I'm Adam Ron. I'm with Bank of America. I'm an equity research analyst covering healthcare facilities and managed care.
Perfect. So generative AI, the healthcare market is rapidly growing, outpacing most industries of yesteryear. The opportunity is large. We know this, we heard in the last session, improved diagnostics, personalized medicine, access to care, worker burnout, drug discovery, and much more. With the market size expected to be anywhere from 22 to 30 billion in just a few short years, I'm thrilled that we have three luminaries to give us a sneak peek into the future of generative AI. This session will cover three main topics: how generative AI will change clinical care, how we can implement generative AI responsibly inside the four walls of the hospital, and the barriers, ethically, politically, privacy, and security-wise. So with that, I'm going to ask each panelist to introduce themselves and tell us what they're most excited about and their predictions for the next 5 years for generative AI in clinical medicine. And I think we'll start at the far end with Dr. Rao.
Awesome. It's a privilege to be here. Thank you. And really quick background. I'm Shiv, founder and CEO of a company called Abridge. We started the company in 2018. A little bit about me. So prior to this, I was an executive at a health system in Pennsylvania called UPMC. I had violated Peter's Principle like 10 times in 5 years, but I got to be their check writer for their investment portfolio. So put capital into startups in their name, but also into Carnegie Mellon. We started a machine learning and health program. And I bring that up because in this new life at Abridge, while we're not a spinoff, we have a lot of founding DNA on the technical side that comes from Carnegie Mellon. I went there a couple lifetimes ago as an undergrad, but in the middle became a cardiologist, and I still practice. I was just on call this last weekend. In terms of Abridge, if you don't have context, we're on that kind of provider experience, provider burnout side of the spectrum, and maybe there'll be opportunity to unpack that in a little bit more detail. But in terms of the specific question that you brought up, time machines are broken right now. We're on an exponential curve, and it's difficult. It's impossible, I think, to have a strong opinion, I think, about what the future is going to look like. I think for us, I think at Abridge, we have 2 points of view about the future. Sometimes it's more useful, I think, to invert the question and think about what do we think is not going to happen in the next 5 or 10 years with AI. And certainly a very strong point of view that we have at Abridge is that in the next 5 to 10 years, there's that Bezosism. What's not going to change in the next 10, that's what you can kind of anchor a company's value proposition against. And one of the strong ideas that we have that we do not think is going to change in the next 10 years is we don't think that AI is going to automate doctors, and we don't think AI is going to automate nurses. Now, believe it or not, that's controversial in some technology circles out there today, and that's a debate that I'm always, I would love to have. I think on the flip, though, I think in order to ride that exponential curve, how do you ride that? And I think at the end of the day, there are 3 scarce resources that allow us to sort of build the future and determine what it's going to look like over the next 5 or 10. And one is world-class people, and that's a really scarce resource to find the ingredients to be able to start to build the future, build against it. And it's on the AI front for sure, but it's also those really interesting outliers who can kind of, sort of move between worlds. It's also proprietary data sets, because that's obviously, it's how you hydrate those world-class people. And then it's compute. It's fascinating to see in the news now how a lot of hyperscaling AI companies are basically declaring themselves energy companies. But yeah, with that, I'll pass over to you.
Yeah, thanks, Shiv. I read recently they're reopening the nuclear power plant, and Microsoft gets all the energy.
Yeah, that's right. Pennsylvania.
So I'm Chris Longhurst. I serve as the System Chief Medical Officer and Chief Digital Officer at UC San Diego Health. And so unusually, IT is part of my portfolio, but I also get to see all the problems from our CMO kind of landscape. And so I'm really privileged that AI is a new tool to help us solve some of those problems. My background, I spent 15 years at Stanford before coming down to UC San Diego for this executive role. And I have a strong technology background. My master's thesis 25 years ago was in AI. The prediction for what's going to happen, I'm going to put out a couple things I'm excited about and things I'll predict. First of all, I think it's been well demonstrated by Abridge and others that AI is going to be a really critical tool for helping mitigate burnout. And we'll talk a little bit about some of our early experiences with AI for answering patient messages as an example. But where I'm really excited about AI is actually improving quality and safety. So it's been 25 years since the Institute of Medicine published their landmark report suggesting that we kill 50 to 100,000 Americans per year through medical errors. And Dr. Bates showed just last year, we really have not improved. And so we need new tools in this battle. As the CMO, I see these cases on a weekly basis, and you just grimace and you think, what could we have done differently? And I think there's tools now that really can make that difference. So quick scan of the audience. How many of you have a friend, family, or other loved one who suffered from a diagnostic error, misdiagnosis or a delayed diagnosis? So at least 1 in 4 of you in the audience. It's the leading cause of medical malpractice lawsuits. It's also the leading cause of medical malpractice settlements. So my prediction, Marc, is that in 7 to 10 years, I think that we're going to see AI helping improve diagnostic safety in a massive way. And I'll go a little bit further and make a controversial prediction. I'm going to actually posit that in 7 to 10 years, there will be a large language model that is licensed to practice medicine. Wow.
On that note, Rebecca.
On that note, I'm not sure I'm going to go that far. My name is Rebecca Mishuris. I am the Chief Medical Information Officer for Mass General Brigham. I'm also a practicing primary care physician. So I get to use all of these tools in my practice as well. And you know, if I look 5 to 10 years out, my first reaction is that I have no idea, because 2 years ago I would not have predicted where we are today. That being said, right, I think we can see the writing on the wall, and it is clear that AI is going to drastically change how we practice medicine. It's already starting to do that with some of the tools that are focused on reducing administrative burdens and actually improving, as Chris mentioned, clinician burnout, and we'll talk about some of those tools later, ambient documentation. But it's not just going to be for the physicians, it's going to be for the advanced practice providers, it's going to be for the nurses, it's going to be for the therapists. It's really going to touch the entire care team as we move forward here. What I think actually is super exciting is kind of riffing off of Chris, actually, that we are going to see these tools improve the care that we're delivering. They're not going to deliver the care on their own. Sorry, I don't think so. But they're going to improve they're going to make me a better doctor, right? And so they're really going to augment my ability to deliver safe, effective, and equitable care. And I really want us to see us as society drive towards that equity principle as we implement these tools. That has to be kind of forefront of what we're doing. Because if we're driving quality, equity is inextricably linked to the quality of care we deliver. So that's where I'd put us 5 to 10 years from now.
So if we look back at the last 20 years in terms of like internet adoption and some of these like Web 1.0, 2.0 companies, and it feels like healthcare has been on a significant lag in terms of probably the rest of the economy in terms of adopting technology. And of course there is technology, but it doesn't really compare to how like consumer-facing apps look. And so I wonder if you guys think AI will be similar, that there will be like a huge lag in terms of what we see in the consumer side of AI adoption and then in healthcare, or if you think this time will be a little bit different for some reason that you see.
Well, I think it's already been different. I think healthcare, you could argue, is moving faster than any other vertical industry right now in terms of its adoption of AI. Certainly we have the numbers to demonstrate that. It's wild to think about this moment too. So tracing it back, we started our company in 2018. It was 3 months after a paper was published called Attention is All You Need. And it was out of Google Research, and it was a paper about this new type of machine learning model called a transformer. We could not have predicted in 2018 that in 2023, people would start to realize that the T in GPT stands for transformer, and that we'd been sort of working on generative AI all this time. But in 2023 or late 2022, a few stars aligned, and I think that's what's led to the sort of inflection that we've seen over the last couple of years in healthcare. One is we have a public health emergency right now, whether we like it or not. There are 2 out of 5 doctors per some surveys who say they don't want to be doctors in the next 2 to 3 years. There was a JAMA article I read recently that suggested that 27% of nurses don't want to be nurses in the next 12 months. You talk about burnout, you talk about cognitive burden, and we're just off the charts compared to any other profession. And so when I hear from patients or when I'm on call and I see that patients have driven 3-4 hours from a rural sort of setting in order to come see me in the academic medical center, clearly something is wrong and something is broken and we've got to fix it. And so I think that became an existential priority for executives across the country, like over the last couple years. I'd say it's been sort of a buzz phrase at conferences for the past 10 plus, at least as long as I've been in attending, but it became something really, really important to prioritize in just the last couple. But then that alongside ChatGPT coming out and all of us playing with it and all of us starting to recognize what could be possible with this technology in an industry where over 80% of the data is unstructured and is really centered around language and text. There's so much potential for this type of technology, for a large language model to really take off and create value. So I think on one hand, we're seeing an inflection, and on the other hand as well, and I think both Chris and Rebecca are great examples of this, I think we're also seeing over the last couple of years an incredible, almost overnight evolution, maturity, sophistication around how we think about generative AI in healthcare. Because it started out in 2023 as like really cool demo, like cool demo bro was like the refrain certainly I heard over and over in 2021 and 2022. And then all of a sudden in 2023, it was like, let's try this. But then it was like, let's test this, let's measure this, let's demonstrate the ROI, because there's always the CMIO, visionary, there's the CIO who needs to think long-term in terms of technology stacks, and then there's a CFO who absolutely is going to hold any of these technologies to the fire, their feet to the fire in terms of demonstrating something that they can, validate or legitimately pay for. So all of that evolution, I think in healthcare is happening faster than any other industry right now, but I'm curious if you guys agree.
Yeah, so I fundamentally agree with your narrative. It is happening very rapidly. And I'll just provide sort of a different frame of context or perspective. You talk about kind of the adoption over the last 20 years of, you call it internet, let's call it electronic health records or automation, right? And there's fundamentally a couple things to point out if you're not inside the healthcare vertical. One is, the delivery systems operate on grocery store margins, right? Most hospitals have 2 or 3% margins, so they're very thin margins for investment. Secondly, these investments in electronic health records have not had an ROI. In fact, they've cost more money. And a lot of reason that we put this in was to have the digital infrastructure and improve quality and safety. But it now costs us more money to run the hospitals because of the IT infrastructure. And so it's important to recognize that as we've made all these investments, we couldn't be doing these things in AI without the investments that have been made. But now AI is much more attractive to the CFO and others because there's so much friction in the system, so much waste that AI can help to automate and take out of the system. And so our interest in moving quickly is not only for clinician burnout, but as you suggested, is also for things like efficiencies that we can measure from a CFO perspective.
I think even from the CFO perspective, and my CFO is somewhere at this conference today, right, there is an understanding that it doesn't have to be hard dollars, right? The benefit of ambient documentation, for instance, is going to be in burnout. Yes, you can actually translate that to dollars because it costs money to replace a physician, but you've got to be a little bit visionary in thinking about how these products are going to improve the quality and experience of delivering care. And that becomes incredibly important as we think about where the tools are actually going to be appropriate for use. They're not the right answer for every problem that's out there, but they are going to be the right answer for some of our problems. And for those, we do want to show that there's a return. And guess what? That's actually no different from any other technology we've ever put in, right? We want to know that it's actually improving the care that we deliver in some way, whether that's from a quality perspective or safety or patient experience or provider experience or equity. Right? We really want to show that the technologies are having that impact. And Shiv is right. We are at a point in healthcare where healthcare is broken, right? We know how it's broken, but we have not had the tools to fix it in any meaningful way until now. And generative AI in particular, right, is giving us that opportunity in ways that we've never had before. Also, I'd like to get rid of the fax machine in my clinic.
You've all given us a lot to think about, these real brilliant points. We can spend another hour on this, but I'd love to dig deeply into some personal work you each are doing and give you a chance to describe that. And maybe starting first with Chris. You recently published a JAMA Network Open study analyzing the use of generative AI enabled physician response to patient messages. I'm wondering if you could tell us a little bit about that study, but also how you see generative AI might affect positively or negatively patient-physician communication.
Yeah. Thanks, Marc. So first of all, a little bit of background on that study. In 2023, we published a paper out of UC San Diego looking at generative AI drafted responses to patient messages on Reddit. And it got a lot of attention because the headlines were sort of clickbait. It was GPT chatbot, higher quality and more empathetic than doctors. And that wasn't my takeaway as a co-author of the study. It was really obvious which ones were the chatbot and which ones were the doctors, because the doctors had 4 sentences and the chatbot wrote 4 paragraphs, right? It wasn't always right, but the takeaway was that I'll put my doctor up against a chatbot any day if they have 10 or 15 minutes to write that response, right? It's really about time. And so that inspired us to look at, could we use this in a production way to help save our clinicians time? And it was a really interesting study and finding. So first of all, we randomized our physicians as a quality improvement initiative. And we rolled out this tool first in the country to see if draft messages that were drafted with GPT could help our doctors save time and reduce cognitive burden, et cetera. What did we find? Well, it turned out before the study, before the AI, it took about 30 seconds for a doctor to type a message to a patient. Now, it might be a couple sentences. After the AI, it took the doctor about 30 seconds to read the patient message and edit the 4 paragraphs to make it accurate and send it. And so it turned out it didn't save time, but it did reduce cognitive burden. We all know it's much easier to edit someone else's copy than it is to stare at a blank screen, right? In fact, our partners at Stanford also published a study at the same time showing reduced burnout. And so we're in the process now of scaling and expanding that across the institution, but not with the expectation of time savings, rather with the expectation of being an assistant that helps our clinicians. In fact, one of the things we're learning more recently is that many of our procedural areas, cardiology, GI, et cetera, have mid-levels and nurses answering messages, and it turns out it'll probably be much more effective in saving them time and helping out our mid-level providers as well. So lots of lessons learned, but to me the takeaway here is, as Rebecca said, when we implement these things in care, we have to carefully and rigorously evaluate what they do. In fact, we'll probably get at some point to some of the legal concerns, and right now we're at a point of innovation where we're asking the question, do these help? And as we start to demonstrate that they do help, there will be a point at which they become standard of care, and then the question is going to become, why aren't you using them?
Totally.
Can I add just one thing to what Chris was saying, because I think it's super important. The technology alone is not what is having the effect, right? It's the technology and the people and the process, and that triad is incredibly important, because you can take that exact same technology, implement it in a slightly different way, in a slightly different environment, and not see the same effects. And so it's not just about the tech itself, right, the code, it's about how we implement it, and that becomes incredibly important as we try to take what Chris is seeing in California and bring it to Massachusetts, right, or vice versa for some of the other things we're doing. And so I want to make that point, particularly in this room of technology folks, right, that it really has to be about the implementation science in addition to the technology.
Yeah. One thing I'll add too, I think like that both of your words I think sparks in my head. There was an article in the American Journal of General Internal Medicine that came out last year that suggested that doctors need 27 hours a day to get all of their work done. So just from...
Or amphetamines.
And so that inbox issue is like, of course, my note back to a patient is going to look like a choppy one-line bullet or something like that.
Yeah.
And at the same time, the refrain of 2023 that I remember that is now etched in my head is that doctors who use AI will replace doctors who don't. And so I think we're in this moment right now where we're all figuring out how to actually embed this as standard of care and
Yeah.
to see what top of license actually looks like. I don't think any of us actually know with AI.
And to your point about the 27 hours a day, it's been measured what those 27 hours are, right? Doximity did a great survey of physicians who are practicing and found that the opportunity for AI is greatest not in inbox management, which on average takes our primary care physicians about 15 minutes a day to answer 30 patient messages.
Yeah.
but it's greatest in documentation, and that's where ambient documentation tools like Abridge become so critical as burnout mitigators, because they can take what used to be several hours of after clinic work and reduce it substantially.
If I could follow up on that, Shiv, at Abridge, you guys have been featured for some remarkable progress to date. What is the provider feedback on integrating Abridge, and how do you see it affecting the patient-doctor relationship?
Yeah, absolutely. Our kind of first principle is that healthcare delivery is about people. It's not about technology, and those people, they're having conversations. Dialogues really drive everything in healthcare. And those conversations are upstream of not just clinical documentation and clerical work like order entry that maybe crushes my soul at night for sure, but it's also upstream of coding, of risk adjustment, of clinical trial recruitment, of care management, of clinical decision support, experiences, ultimately we think outcomes. And so the ability to be there in the conversation, in the background, and to us the right metaphor from a product perspective is good air conditioning, where when it's set right, you're not aware of it. You're just comfortable, you're just in the moment focused on other things, and in the case of a clinician, on the patient in front of you. And so when you can just focus on the person in front of you, what happens to care? And we've been able to measure this. So on the clinician side, we've been able to see that sometimes within 6 weeks, we're seeing a 60% reduction in cognitive burden. We're seeing significant improvements in clinician burnout, and we're using validated instruments like the NASA TLX, like the Stanford survey, for example. But that kind of impact is really, really important. I think it's important to reflect upon, because at least as long as I've been practicing, I haven't seen anything, move the needle like that. And so it's wild to think that as significant of the impact as the impact has been at this stage in 2025, we're still in the earliest of innings here. And back to the time machine question that you started things off with, it's like how it's so difficult, but also so exciting to think about where we might be going in the future. Just to sort of bring home the value, there are certainly metrics. There's certainly the CFO metrics around what this can do for fee-for-service coding or also risk adjustment. But I was opening up my phone earlier, and I've read this quote in it recently in another talk as well, but it's my favorite. So we use Slack to communicate with each other as a company at Abridge. And every day we're getting thousands of pieces of feedback from clinicians across the country, which I think is heroic in and of itself, that any doctor is taking a second, because they need 27 hours a day, to send us even constructive feedback on where we messed up or where we could improve. But the positive feedback, we also sort of programmatically, we route it into a specific channel that we called Love Stories. And so when we started the company in 2018, I remember we used to tell each other we all needed to be hope camels, like a drop of hope of positive feedback should get us through a desert. Because you're to mix as many metaphors as I can, you're eating glass and learning how to digest it when you first start a company. But now it's like a waterfall every day. And we had this one quote in Love Stories that's my favorite. I'm gonna put it on a t-shirt. And this comes from a rural health PCP. And she wrote to us some time ago, "I was sitting at dinner last week and my son asked me, 'Mommy, why aren't you working right now?' I literally took my phone out and explained to him that Abridge is a new tool that lets mommy come home early and eat dinner with her family. I started to tear up and looked over at my husband, who then said, 'Mommy's gonna be able to eat dinner with us every night now.'" So the impact we can quantify. I think we can get to those CFO metrics, we have to. And at the same time, I think this kind of impact, it's kind of unbelievable to me that we don't measure this and we don't value that kind of impact. And I think that that's something that we as a system, as a society, we need to figure out how to do. But because it's not only there on the clinician side, it's also there on the patient side as well.
So just from the health system perspective of having implemented these ambient documentation technologies, we're hearing and seeing the exact same things, right? And so we're following about 24 different measures in terms of the outcome and impact of ambient documentation. We're looking at burnout, right? So we've seen a 40% reduction in burnout amongst clinicians who are using ambient. There is no other tool, process, intervention that affects burnout like that. And we're actually hearing from our providers, 80% of them say that they're able to spend more time with their patients. They're paying more attention to their patients. So this is a technology that is literally putting me back in the room with my patient and allowing me to spend more time with them, which is really why we all went into clinical care to begin And we have various, same stories, right? I have one of my providers who says she's now able to go to her kids' soccer games and gymnastics meets on the weekends because she's not documenting anymore, right? People who are able to get home for dinner. It is changing people's lives, not just their work lives, but their entire holistic life as a human being in ways that really no other intervention and certainly no other technology has.
So I'm going to take a little bit of a controversial stance.
For sure.
I love these technologies, and I agree. We're seeing the same things, but it's a Band-Aid. So in 2018, inspired by some work I was doing in other countries, we looked at note length in various different hospitals in the US and other countries. And the average physician note in the United States is 4,000 characters. The average in other countries is less than 1,000, about 800 characters. Why are we writing these tomes in the US? Well, it's for compliance, regulatory, and other perfunctory purposes, right? Billing. And so what we're doing right now is we're automating these very detailed notes in order to satisfy our own billing requirements. In fact, Seema Verma, who was here in 2018, announced this Patients Over Paperworks initiative and cited our paper because she was looking at how do we reduce the onerous billing requirements that we've introduced. I was born here in Boston. I was looking at my pediatric record recently, and the whole record fit on like one page because it was like, doing well, height and weight, right?
Yeah.
So in the 80s and early 90s, we in the United States and CMS put in onerous documentation requirements to support billing requirements that have created this issue of burnout that we're now solving with AI. And so if you look in other areas as well, RevCycle is an example. I mean, we've got hundreds of coders coding up charts, and it's a huge opportunity. We have prior auths that drive our physicians nuts. So what are we doing? We're trying to automate them with AI. What are the insurers doing? Automating their denials with AI, right? So we've got an escalating kind of war of AI here, and so we can't keep losing sight of fixing the fundamental problems in our healthcare system in addition to automating things and reducing friction.
Well, I think to meet you where you are, like I think that we're definitely already in this world of AIs battling AIs to some extent.
Yeah.
And there's the now moment that we're in, and there's also maybe a first principles way of thinking about regulation that's like upstream of any technology and how we can maybe figure out how to not hate the players but like change the game itself.
Yeah.
And I think in the world that we're living in, even baked into the name of our company, like after every single patient that I saw yesterday in the hospital, I'm hyper cognizant, of course, because of Abridge, that I'm serving multiple masters for every single note that I create.
That's right.
I'm writing a note for other clinicians, other doctors, nurses, medical students, fellows to read and get a sense of my differential. Why did I choose the cardiac MRI instead of the echocardiogram? That's great. I'm documenting for them so that we can all deliver better care. I'm also documenting for RevCycle because I'm the worst at thinking about those folks. And in the outpatient world, I'm probably the worst at, like I always say history of, for example, and that's like the bane of people's existence. Now all of a sudden you can't
upcode.
You can't get full credit because I did talk about the diabetes, but I said history of diabetes, and now all of a sudden that's a problem. How could I, as a clinician, memorize tens of thousands of rules against all the different patients who have all the different plans and all the different geographies? It's impossible. I remember I used to be on a CDI, a clinical documentation improvement team at UPMC, and we'd go to, from specialty clinic to clinic to clinic, and we'd do these lunch and learns, PowerPoints and pizza. And we'd give all these doctors pizza, and we'd try to convince them this is how you write an assessment and plan to demonstrate medical decision making so that you can get full credit. Every single doctor, 1,000-yard stare. Nobody wants to be told any of these rules or how to write a note for RevCycle to make money because that's not why they went to med school. They went to care for people. And then there's the third constituent beyond other clinicians, beyond back office RevCycle folks. There is the patient, the most important person. And they have access to my note. And then they go to the portal and they see a term like transcatheter aortic valvuloplasty. And understandably, I get epic inbox messages, and I don't have an AI agent yet to like automate my reply. And they're asking, what was that word? I just Googled it. It sounds scary. What am I supposed to do? So this is actually an incredible challenge for AI. It's style transfer. How do you have one conversation, focus on one person, the patient in front of you, and how do you leverage AI to build the bridge between all those people? I think that's certainly where we're focused, but I think that there's a way to get back to that pediatric report that you were born with, you know, like to find a way to create the note that we want to read.
Well, you want the 10-year, prediction, right? We're not going to discreetly document anything, right? It's just going to be in the record. RevCycle will be able to pull out what they want. Somebody else, walking into the room, brand new patient, will be able to pull out what they want. And we'll create that record for the patient so that they can understand in terms that they can actually comprehend what's going on with their care and what are they supposed to do at home to facilitate and be a member of that care team. And so, you'll have this, I don't know that it's 10 years, maybe it's 20 years from now, right? But you'll have a kind of learning system where all of the data exists at the base, and you just serve up what each given person needs at the time for whatever purpose they have. I think that's probably 20 years.
I was hoping like 5.
Brilliant conversation.
I'm not sure, we'll split the difference.
Great conversation. By the way, we're going to have a couple minutes for questions after the next one. So if you have one, think about it. We'll have a mic runner. I do want to just ask and move ahead since we talked about implementation. I have another question for you, Rebecca, and all panelists, is that we all went to medical school for one reason or another. As leaders in AI, what would you tell prospective medical students, folks applying, and folks wanting to become doctors? What would you tell them today about the future?
Oh, what would I tell? I mean, I would tell them that the future of medicine is actually taking care of patients, right? The reason that you went to medical school will be what you do. You won't have to care about RevCycle. You won't have to care about discreetly documenting the blood pressure, because if you don't put it in the right place, you don't get credit for it, right? You'll actually be able to take care of patients. But in order to do that, you're going to have to understand that and work with the technology. And so to the extent that we can start to embed that into medical training and education, we need to start now so that people understand what are the limitations of these technologies, how can we make them better. One of the biggest problems we have right now actually is this idea of non-determinism, which means that you can ask the same question of ChatGPT 5 times and get 5 slightly different answers. It doesn't matter so much if I'm looking for a recipe or where to go for dinner, or even if I'm giving a patient directions for how to get from here to there, right? You can turn right and then left, or you can turn, right and then go 2 blocks and then turn left. It doesn't really matter. But when we start getting into clinical care and actually providing clinical diagnostic reasoning support to our providers, then it really does matter, right? And we've got to figure this out. And so if we can get our kind of early stage trainees and students thinking about that and interacting with the technology and coming up with how we can address the current limitations so that a decade from now, those won't be the limitations anymore. I mean, we'll have different ones, don't get me wrong, but we'll have overcome those and really start to be using these in care.
Brilliant. Chris?
I'm going to borrow Shiv's comment, which I 100% agree with, which is that clinicians using AI will replace clinicians who are not. So I have zero concerns about our doctors of the future, because they're already coming into medical school using GPT for their homework. So they're going to be fine.
Shiv, anything to add?
Yeah, I 100% agree with Rebecca. I don't think I have anything great to add to
Perfect.
that one.
Questions in the audience. You can put up your hand if you have a question for any of our panelists.
Hi, I'm Nick Bryant. This is sort of a question for all of you. Building on the fact that we've now had these rich data sets in these patient notes, how are you thinking about creating insights out of those patient notes for things like recommending screenings or changes in drug treatment? And what do you see as the model there, given the considerations around what Shiv mentioned, proprietary data sets, but as well as patient privacy?
Well, maybe I'll start on this one because it's something that we're doing today. And credit to my CEO and colleagues, we've set up an entire population health services kind of organization. We're part of accountable care groups. And so we have some upside and downside risk in caring for populations of patients. In that setting, we've instrumented 5,000 patients with remote monitoring, and we're doing proactive outreach. We're doing opportunistic screening, right? We can go back and look at the 60,000 chest x-rays that were done in the emergency department, and we can screen them for things the radiologists weren't looking for, like isolated lung nodules, et cetera. And so there's a lot of opportunity there when the incentives are aligned. And I think that the challenge is just in many things in healthcare, the incentives aren't aligned. And frankly, when we look at prioritizing our opportunities, sometimes it comes down to well, which ones are going to be revenue generating? We have to do those first, because even though these others may be important from a quality and safety standpoint, it could actually sap money out of the system.
You bring up a really important question around patient privacy, right, and data privacy and data security. And we are, Shiv mentioned that most of the data in healthcare is unstructured and, quite honestly, unintelligible from a computer perspective, right? Healthcare data is some of the most, if not the most complex data that's out there. And we're now moving more and more of that data around between our systems. And so we absolutely have to keep at the forefront this idea of security and privacy of that data, right? We are stewards of that data. Our patients have entrusted us with that, and we are responsible for it. And so if I have to record a visit with a patient, right, to do ambient documentation, I better know where that recording is going, who has access to it, and what's going to happen to it next, right? From our perspective, we don't actually want that recording out there, right? It's another opportunity for a cyber incident. Also, we want there to be a single source of truth of what happened in that visit. And so, yes, you need that recording temporarily, but you don't need it long term. The flip side of that, though, is that these systems continue to learn. And if we take the data back, right, if we don't allow that data to be used to continually improve the systems, we're actually losing some opportunity for innovation and improvement of the technologies itself. So we've got to strike a balance between those two things while ensuring our patients' privacy and security, also allowing for innovation of the technologies.
Becca, can I build on something you said? Because I 100% agree. And there's an interesting aligned opportunity here, which is as we experiment with these on-premise small language models, that still have billions of parameters, we probably don't need GPT 4.0 level compute in order to do things like ambient documentation. And so we're very excited at UC San Diego and the University of California about things like doing ambient documentation on premises so that we don't have to create security risk by uploading data to the cloud, and, Shiv, lowering the cost dramatically.
Yeah. I mean, I think that you're speaking to something that 100% is music to my ears as well. For us, being able to learn is a part of how the market has gotten a lot more sophisticated in terms of how they think about who to partner with. Because if you're in a space where you'll never be perfect, and off the bat, you'll never be perfect, you'll never meet everyone's demands. And speaking as a doctor, I know that many of us are edge case assassinators. You make one mistake and you're dead to me forever. And so if you're in one of those spots working on a use case that's never really going to be perfect, but when more data can help you train a model or deliver an experience that's less imperfect, then you're looking at spending tens of millions, if not hundreds of millions of dollars over time to invest in all the R&D to win the market, to deliver the best, most premium experience. And that's where the proprietary data sets, the world-class people, access to compute really comes in. So today we'll have tens of thousands of conversations in California spoken in Spanish and Mandarin and Vietnamese. Today in Boston, there's a doctor or many doctors speaking in Haitian Creole and Brazilian Portuguese. And today in Indiana, there's a PCP speaking in Punjabi to her truck driver patient population. Blows my mind that they don't need interpreters. But one of the reasons why we can support multilingual conversations is that we have partners who allow us to train in a responsible way where this is de-identified data for a finite period of time that allows us to be, that much better every time.
Important point. Can I say something I've been waiting to say on a panel for a long time? So in this escalating battle of AI that we talked about, I think one thing is certain as the AIs battle each other, that I'll be back.
I was going to ask for another question, but I think we'll end it with just a movie reference. These panelists have given a lot for us to think about. Please come up and ask us questions and enjoy the rest of the forum. And a big thank you to all our panelists.
Thanks, Marc.
Thank you.